Hey everyone, आज हम एक बहुत ही high yield topic उठा रहे हैं, anemia in pregnancy. ध्यान से सुनना, because whether you're sitting in your final MBBS exams, grinding through NEET PG prep, or just managing patients in the wards, the management protocol for this is something you absolutely must know on your fingertips. We're going to do a rapid, high-yield revision, breaking down some classic clinical notes into crystal clear concepts. So, let's get right into it.
Here's our rapid roadmap for this session. 1. Management protocol. 2. Oral iron rules. 3. Parenteral iron. 4. The Gonzoni formula. 5. Blood transfusion. And finally, 6. A rapid revision. Quick and easy.
All right, Section 1, Management Protocol. Let's look at the algorithm. The absolute most crucial thing to remember here, your whole game plan depends strictly on just two variables. First, the patient's hemoglobin level, and second, her gestational age. It's like a giant puzzle, but once you see the pattern, it's super easy. We've got this master flowchart that maps out every scenario from mild to severe, but let's break this raw data down into something you can actually memorize in a snap.
ध्यान से देखो इसको. This is pure MCQ gold. The absolute magic number you need to lock in your brain is 34 weeks, okay? So for mild to moderate anemia, that's an HP of 7 to 9.9. If she's less than 34 weeks, you have time. First line treatment is oral iron, 2 tablets a day. But if she's at or beyond 34 weeks, time is running out before delivery, right? So you switch gears immediately. Seetha parenteral iron. Now what about severe anemia? HP less than 7. If it's dangerously low, like under 5, it literally doesn't matter what the gestational age is, you go straight for a blood transfusion, no second thoughts. If she's hovering between 5 and 6.9 and she's at or beyond 34 weeks, again blood transfusion. But if she's less than 34 weeks with that same 5 to 6.9 HP, well, then we look at the trimester. First trimester, strictly oral iron. Second or third, go for parenteral. Fundas clear? Awesome. Chalo आगे बढ़ते हैं.
Moving on. Section 2. Oral iron rules. So we established that for early, mild to moderate cases, oral iron is our go-to weapon of choice. The standard starting dose is 2 IFA, iron folic acid tablets per day. But listen, just handing over the prescription isn't enough. You absolutely have to assess if it's actually working. Which brings us to a classic professor's trick question straight from the wards. Your patient comes back after starting her oral iron. What is the preferred parameter you check first to see if she's responding? Think about it for a second. Is it hemoglobin?
If you said hemoglobin, you just fell right into the trap. The correct answer and the absolute earliest indicator is the reticulocyte count. It peaks really fast, usually within 7 days, maximum 10 days. Hemoglobin? That takes time. It only really starts bumping up significantly after the 3rd week at a rate of roughly 0.7 grams per deciliter per week. So always use the retic count as your early warning system.
Now, practically speaking, how do you check for compliance? Sachi mein dawai le rahi hai ya nahi? It's simple. Ask about her stool color. A compliant patient taking her iron tablets will have dark stools. If she does, and her response is adequate, you maintain those 2 tablets a day until her HB hits 11 gram%. Once it hits 11, you drop it down to a maintenance dose of 1 tablet a day, and she stays on that throughout the rest of the pregnancy, plus 180 days post-delivery to replenish her stores. But if her stool color is totally normal and her HB isn't budging, like less than a 1 gram increase after a month, that's a red flag. She's either non-compliant or the therapy is failing. That is your cue to switch over to parenteral options.
All right, Section 3, Parenteral iron.
So, we step up to injectable therapy when oral iron fails, when the patient literally can't tolerate it, or when we're just out of time, meaning 34 weeks or beyond. These injectables are a total game changer, but you gotta know your generations and when to avoid them completely.
Let's look at the preparations actually approved by the government of India. First generation is iron dextran. Honestly, just forget about it. It's an IM injection, super painful, stains the skin. We don't really use it anymore. Second generation is iron sucrose. Now this is your absolute workhorse. It's given IV, it's very safe, and definitely the most common one you'll use in the wards. Third generation is ferric carboxymaltose, or FCM. Clinically speaking, it's the premium choice because you can give a massive dose in a single sitting, but it's pretty expensive, so iron sucrose usually takes the crown for daily practice.
But beware! There are absolute contraindications. You never give parenteral iron in the first trimester. Let me repeat that. No IV iron in the first trimester. Huge example right there. Also, totally avoid it if there's an iron overload condition like hemochromatosis or if the patient has thalassemia major, meaning they are Nesterov test positive. Just don't do it.
Next up, Section 4, the Gonzoni formula.
Okay, so once you decide you need to give parenteral iron, you can't just guess the dose. अब थोड़ी math करते हैं. The Gonzoni formula gives you the exact total iron deficit in milligrams. Here's how it works. You take 2.4, multiply it by the patient's pre-pregnancy body weight in kgs, and then multiply that by her hemoglobin deficit. The deficit is just your target HB, which is 11, minus her current HB. Then, and this is crucial, you add 500 milligrams at the very end. ये 500 क्या है? It's a constant. We add it specifically to replenish the completely depleted iron stores in a body. रट लो इसको. Memorize this formula. It's gonna save you on the floor.
Now, even with your total dose calculated, you cannot push it all at once if you're using iron sucrose. There are strict speed limits to avoid toxicity. The absolute maximum you can give in a single day is 200 mg. That's usually 2 vials. Alternatively, you can do a maximum of 600 mg per week, spreading it out as 3 injections on alternate days. Safety first, iron overload nahi karna hai.
Moving to Section 5, Blood Transfusion. What happens when things get really critical? This is the final, most drastic step in our treatment ladder. These are your absolute life-saving indications. If her HB drops below 5, it literally does not matter if she's 12 weeks pregnant or 38 weeks pregnant. She needs blood immediately. If her HB is between 5 and 6.9 and she's hit that 34-week mark, give blood. Other absolute indications include thalassemia major, or if she's presenting with heart failure, acute hemorrhage, or bone marrow failure. In these life or death scenarios, packed cells are your only option to rapidly stabilize her.
All right, almost done. Section 6, Rapid Revision. Let's lock this in.
We've covered the main protocol, but let's quickly touch on folic acid, which was tucked away in those original notes. The standard treatment dose for a folic acid deficiency is 1 milligram per day, but examiners love to trick you with this. If your pregnant patient has sickle cell anemia, her requirement skyrockets. She needs 5 milligrams per day. Folic acid की dosing में exam में बिल्कुल confusion मत करना.
Okay, I want to leave you with one last retention check to see who is really sharp today. If your patient successfully hits that target HB of 11 gram% using oral iron, exactly how long do you keep her on that 1 tablet a day maintenance dose? Come on, think about it. The answer? You continue it throughout the rest of her pregnancy, plus 180 days post-delivery. Never stop it the second she hits 11. Otherwise, she's going to crash right back into anemia during lactation. And that is the whole shebang. I hope your concepts are crystal clear now. Keep revising, and I'll catch you in the next session.